must constantly look at things in a different way.
The Healthcare Education Transformation Podcast was created by two physical therapists out of the desire to learn more about the different educational roles in physical therapy and healthcare, and how healthcare education works by talking with educational leaders and people with different perspectives within physical therapy and across interdisciplinary lines on how education can be improved to disrupt the status quo of healthcare education. This is our journey, and thanks for listening. Are you a third-year physical therapy student that excels on tests when you have study guides, checklists, and deadlines? With all of the information available about how to prepare for the NPTE, it's easy to get disorganized and not feel prepared going into the big day. NPTE Prep Success is an online course that provides PT students easy-to-use study guides and step-by-step guidance through the NPTE preparation. To learn more, visit kylericeprep.com. Thank you again all for your continued support, and now for the show.
All right, welcome everybody to the Healthcare Education Transformation Podcast. My name is Daniel Dale, and I'm a doctor of physical therapy and an assistant clinical professor at Mercer University in Atlanta, Georgia. I'm guest hosting our chat today as we continue our journey through the efforts of simulation in PT education and healthcare education as a whole. I'm pleased today to be joined with Dr. Susana Barroso-Fernandez, who is the Assistant Professor of Clinical and the Director of the Simulation Hospital Special Projects at the University of Miami, as well as Dr. Martha Bloyer, who is a board-certified pediatric clinical specialist and is in the Department of Physical Therapy at the University of Miami and the Mailman Center for Child Development. Thank you both for joining us today to talk about simulation.
Thank you for having us.
Thank you for having us.
Excellent. So what we'll start with today as we kind of get into the topic of simulation and how the University of Miami does it from a physical therapy and a nursing perspective, I want to start off by just starting with how you both have gotten into education and more specifically, what drove you towards simulation. So Dr. Bloyer, if you want to start, tell us a little bit about what got you into education and then simulation education.
Well, thank you. So I have been faculty on a full-time basis since 2006. Prior to that, while I was getting my master's in physical therapy, I had the opportunity to take some courses in curriculum development, and I was a teaching assistant at a public university, and I was an adjunct faculty. So that's kind of how I entered academia, as an adjunct faculty and in different classes, especially some labs. In 2006, like I mentioned, I was hired full-time at a different university, and I've been at University of Miami now since 2015 as full-time faculty.
Excellent, thank you. And Dr. Barroso-Fernandez, how you got into education?
I got into education actually at the bedside. When I was a nurse at the bedside, I was preceptoring a lot of the new nurses, which led me to take a position as a nurse as a nursing director in a simulation lab that was being opened, and they wanted some nursing feedback. So it was the combination of precepting, marrying simulation at the hospital setting, and that blossomed into joining UM's School of Nursing and Health Studies 14 years ago.
Excellent. Thank you both. So a wide breadth of knowledge, both in the teaching realms and in simulation. Now I'll ask Dr. Bloyer, how has the University of Miami simulation program started specific to physical therapy education? Because I'm imagining oftentimes, as we see in most of these programs, simulation starts with our nursing programs. And that's where it kind of starts, in physical therapy is joining the trend. At least that's how it is in my personal perspective. So if you'll tell us a little bit about how simulation got started for you in the physical therapy program.
So absolutely the same as you just mentioned. It's really something that I had an interest in simulation coming from the previous university where I was at. I was introduced to simulation, high fidelity simulation there. And we had some labs for physical therapy, pediatric physical therapy only at the previous university. So when I came to University of Miami, the nursing school was just starting their their new, we're building their new, and Susana can actually give you more information about that, their new simulation hospital. However, they already had simulation there. And so I was fortunate enough to be able to collaborate with Susana. I reached out to Susana and said, I would like to see if there's any way we can do some simulation alongside nursing students, because that's one component that I had not done in the past, which was do an IPE in addition to the simulation. Here in our physical therapy department, over the last 3 years, we have been able to build 2 small simulation rooms that have pretty much most of the features, but they don't have the high fidelity mannequins, and we don't have the opportunity for pediatrics. So that is the other reason why I definitely look forward to and continue to collaborate with the nursing school and nursing in order to provide that pediatric component. I know some other faculty here have been able to also participate in what's called a Patient Safety Week, which was with medical students and nursing students. But once again, those are IPEs, and it's once again the collaboration with the nursing school because they have these beautiful, wonderful simulation hospital.
Absolutely. And I'm going to turn it to Dr. Barroso-Fernandez to discuss that. As I was saying, and as Dr. Bloyer was saying, physical therapy is finding a great partnership in nursing, both within the clinical realm, but also the simulation education. Dr. Barroso-Fernandez, can you talk to us a little bit about simulation from the nursing side and how that got started and kind of how this relationship with physical therapy developed?
It's interesting that nursing is now at the forefront because initially it took us a little bit to join the simulation bandwagon. It actually started with medicine, anesthesia particularly. We joined in the late 80s, early 90s, and as you mentioned, became the forefront. When I joined University of Miami, we actually were doing simulation, had just started looking at integrating it as a mandatory part of the curriculum for every single course that had a clinical component. We started one course at a time, one scenario at a time, and currently at this point, both in our undergrad and our graduate programs, simulation is a mandatory portion of clinical experiences, and it is threaded throughout our curriculum. We went from one room, 3 simulation high fidelity sim mannequins to what we now have, which is a 41,000 square foot, 5-story simulation hospital that pretty much mimics every single portion of a real hospital and allows us to track workflow, patient flow. It includes outpatient clinics and a 1-bedroom apartment. And we use it not only for our nursing students, but we like to collaborate with physical therapy, with med students, nurses, physicians, our community partners. In essence, it's recreating that hospital environment and being able to bring everybody into it and take care of these simulated patients across the lifespan and across the healthcare continuum, from outpatient, home care, acute care, and from infant to geriatric.
That's incredible. Dr. Bloyer, you want to add anything to that?
Yes, and just as Dr. Barroso just mentioned the apartment, I would like to add that in addition to the high fidelity simulation, we were able to use, just last Tuesday, we took our entire neuro class. I do a lecture on environmental assessment. And so we were able to take the entire 60 students over there and we just did a simulation, doing all kinds of environmental assessment in that nice little wonderful apartment that they have there. So it gives the students also an opportunity to learn how to do those home evals prior to going into their clinical experiences.
That's incredible. And that goes along with some of the benefits that we've discussed in previous episodes on simulation, as well as some of the future episodes I know we'll discuss. That opportunity, again, for the students to be engaged in such a meaningful experience, but yet still something that we can control and guide their learning in as well. So you guys sound like you're doing a fantastic job. Dr. Barroso-Fernandez?
And I think the other part of it, it's not only engaging the students, but allowing them a safe space to make mistakes, learn from their mistakes, and create that muscle memory so that when they go into the real world and they're in clinical practice, they have something to pull from and remember and help them.
Absolutely. Excellent. So now let's dive a little bit more into the meat and potatoes of your simulation program and kind of the layout. And again, I know both of you speak from different realms because you do some together in physical therapy and nursing and some separate. But as we think about kind of simulations and how they're included in your curriculum, Dr. Barroso-Fernandez, I'm going to start with you. Talk a little bit about the importance in simulation of debriefing. We talk about that, and I think sometimes that term is thrown around in simulation. And I think we'll probably share the idea that debriefing is one of those most important things to create that muscle memory.
I think debriefing is every step of simulation is the cog in the overall wheel. But what happens with debriefing is we stop being those podium teachers and allow the students to reflect on what they did well, areas for improvement, and what their takeaways are. Especially when we create these scenarios that they may not see in clinicals. We can't control that clinical experience, but we can control simulation. And if you build the simulation with the learning objectives, and then you're able to go through them in that debriefing so that it creates that package for the student to then go back and practice what they've learned in that clinical experience, or even put them right straight back into that simulation to highlight those points, it creates this educational experience that they're not going to get, but we expect them to have when they go out into the real world.
Absolutely. Dr. Bloyer, do you want to add anything on debriefing as it relates kind of to physical therapists, education and debriefing?
Yeah, so absolutely. You know, when the students watch the video, because that's how we do the debriefing. So we play back the scenario that just went on, bits and pieces of it, and students really get the opportunity to do some self-reflection. And so with that debriefing part, it's usually led, the first question is, how did they feel about it? And it's really about their feelings about the scenario. How did it go? Did it go well? Did it go, not so well? What would they do different? So a little bit about the feelings. And so the person leading the debriefing will usually go around the table, around the room, and ask each individual person, how did you feel? And so I think that kind of breaks the ice, that feeling component. And then when they start watching the simulation and the different, how they reacted to the scenario, they really can do a little bit better, if you will, self-reflection than just what they remember they did. They were so nervous maybe the first time they do simulation or the second time that they're being videotaped and whatnot, but really being able to see themselves in action alongside with the nurse or doing their PT portion of whatever that case scenario was. I think that ability to just talk about it is a huge learning experience in itself.
Absolutely. I think that's so important when you talk about that self-reflection piece, especially I think for all three of us as clinical educators. Having a student that has that self-reflection piece going into clinic makes a world of difference in regards to their ability to adapt and respond to feedback. And again, simulation provides that opportunity. So I'm going to ask both of you this, and I'll start with Dr. Barroso-Fernandez. Tell me a little bit about what's unique about the simulation experiences that you use at the University of Miami.
I think there's a couple of things that we've built that make us unique. The biggest thing currently is that 41,000 square foot, 5-story hospital where you completely are immersed in walking into this facility. It allows the students, we're no longer pretending. They're coming in their scrubs. The rooms are designed to look like their clinical sites. So right from the beginning, it's not a game. And then building those interprofessional education moments with physical therapy, with the med students, and being able to create experiences where we have our undergrad nursing students and our graduate nursing students being able to work together and giving them that experience where from the beginning, while they're here in sim, they may be learning in silos in the classroom, but when they're coming into simulation, it's bridging those silos and being able to work together in the environment that they're going to find.
Absolutely. And I'm going to call on Dr. Bloyer, reference your ELC presentation from this last year at the Education Leadership Conference. You guys presented together and talked about not only a unique simulation, but a unique IPE, interprofessional education simulation. Dr. Bloyer, can you expand a little bit on your talk at ELC and talk about what that simulation entails and how PT and nursing are working together?
So absolutely. So first of all, the day consists of not just simulation with high fidelity simulation, but we also had a clinical skills portion. So the unique part about it is Dr. Susana Barroso and I have been able to also kind of match where our students are kind of in the curriculum. So it is an elective course for the pediatric, it's a pediatric elective course for the physical therapy students, and they're matched with nursing students who are in the process or taking their pediatric content in an advanced nursing program that they have. So once again, that matching is, I think, unique that we're able to do that during that time of the year where both students are in the process of pediatric content. So that's unique in itself. And then the other portion of it is that we have that clinical skills portion. So we review all different kinds of IV lines, the different kinds of the valve mask. We review swaddling, diapering. So it's a clinical skills lab and how a PT and a nurse need to work together. For example, if you have a baby in the NICU and you have to position them in a certain way, how do you teach a nurse and vice versa? How does the nurse teach the PT student to what to look out for, what to check for in terms of the line, the Foleys, etc. So I think that's also unique that we embed a clinical skills part. And then in the afternoon session, we did the high fidelity simulation cases.
Excellent. Dr. Barroso-Fernandez, you want to add anything to that?
I think it also gives them an opportunity to see just how similar the education is and to realize that there are so many common threads. Our nursing students were surprised that physical therapy students had a stethoscope and knew how to use a stethoscope. It was like, what? And asking the same questions when we're taking a history. It was that aha moment of we see each other as so different, but we work so closely together and there's so many similarities that it's nice to be able to come together and show them. We're all in this together. We're here to take care of the patient, and there's so many ways we overlap and that we have a unique skill set, but just like the real world, we are more similar than we are different.
Absolutely. I think there's such value to any interprofessional education experience, but knowing where we started with interprofessional education experience was those roundtable seminars where everyone's from a different discipline and they all work on a case together. It doesn't allow that real life skill application where you can see someone in action. And you guys are developing that at the University of Miami, where all of a sudden PT and nursing is in there together and in action performing skills. And like you said, knowing that PTs have a stethoscope and knowing that nurses, we found in our research at our university, nurses do more than medication administration. It was crazy that our students it blew their mind. And that in-action moment just creates such respect and such knowledge of each other in this healthcare game. It's like you said, we're all in this together. So you guys are doing an amazing job. So I'm going to ask a question now, and this is banking on both of y'all's education background as well as background in simulation. What have you seen and learned from your years of doing student simulations for maybe some effective do's and some effective do-nots in how you run a simulation? Dr. Bloyer, we'll start with you.
So some of the effective do's are definitely setting up the case scenarios, and we've worked closely to making sure that the scenarios, the simulation scenarios, have a role for the nursing student and the PT student. So that in itself lends for an effective simulation experience. I think in the past, one of our challenges was making sure that yes, the scenarios kind of fit both fields. And so we've tweaked the scenarios throughout the years to make sure that there's a role for each. Then the do-nots for running the simulation, I think we have come, sometimes challenges and barriers when you have a lot of students. So we've learned that if we keep the groups during the actual simulation to a reasonable amount, and what that number is, it could be, 2 PTs. I try to 2 to 3 PTs. I sometimes say, pretend it could be a CI with a student. So there might be more than 1 PT in a room in acute care. And with the nurses, the same thing. If we keep it to 2, at the most 3, that results in a much better simulation because some of the feedback was initially sometimes that if there's too many people in the room, they kind of lose track of whose role or who has to do what. But that goes back to obviously the effective part is really knowing what the learning objective is. So if we've told them, okay, the learning objective is really about communication with the parent, and they really know that that's the role and that's what they're working on, I think it makes it, a much more effective simulation. So once again, I think it's the two things, keeping the objectives in line, and then the second component is kind of a barrier or challenge has been keeping the groups small.
Absolutely. Dr. Barroso-Fernandez, some simulation do's and don'ts from your experience?
I'm going to start with the don'ts. We get so excited writing a scenario and we want to make it the most amazing, complex, oh my God, throw everything at it scenario. And we forget who our learners are. So don't create a scenario that's going to be impossible for the students to get through. And don't make it so difficult that they throw their hands in the air and walk out. You've lost them at that point and they're not going to come back. Another thing is simulation isn't a lecture. So your debrief isn't a mini lecture. PowerPoints shouldn't be thrown up there with, let's review what you forgot. It's for the students to be able to learn and reflect. So a do is let the students talk and let them even guide their own debrief, I think is really important. Don't lose other students in the debrief. Students will try to shy away from commenting. Make sure that you pull the quieter students into the debrief, but don't let it become a bitch and moan session. I failed because you made the simulator do X, Y, or Z. Doesn't help anybody. So I think one of the biggest do's is that pre-brief and establishing expectations of simulation and debriefing so that the students have a very clear, for lack of a better word, rules of engagement, what can happen, what isn't going to happen. And I love Harvard's basic assumption. We know you're here to do your best. We think you're intelligent and you want to learn, versus having the student come in with that us against them, you want me to fail, you want me to look bad.
Absolutely. You guys both share some great points. I agree with you on both of those. The challenges we've heard about creating scenarios that are meaningful with the right amount of students and the right amount of time. And then I love, Dr. Barroso-Fernandez, how you keep presenting that where it's not a podium, it's not a lecture. It's allowing the students to debrief. And I think that comes from where you both have talked about creating that safe environment, not only for the simulation where the students can go in, try their best, utilize their knowledge, and make mistakes, safe mistakes, but then also to reflect in a safe space with their colleagues and know that it's okay, that it's not supposed to be perfect, and that's why we're working on it. So I think you guys are doing excellent. So I wanted to talk a little bit about one of the concerns that comes up as we talk about simulation in any regard, and that's talking about finances. As we think about finances, do you have any feedback or any ideas of how faculty or programs can successfully advocate in regards to simulation to the higher ups in the universities? Dr. Barroso-Fernandez, I'll start with you because nursing has been fighting this battle for a little bit longer at this point.
I think one of our guiding principles is, yes, simulation exists, but just because you have simulation doesn't mean it's always the best fit. People want to build huge simulation centers and use simulation for everything, especially high fidelity simulation. I think it's having that simulation champion that really understands how simulation is best utilized. So from the finance point of view, you need a champion. You need someone who understands simulation, the levels of simulation. And you don't need 15 different simulators, or everybody goes crazy with the newest, bestest, oh my gosh, who's put out the greatest simulation with all of the bells and whistles, or simulators with all the bells and whistles. When you look, sometimes a low fidelity simulator for the objectives of your scenario or the experience that you're trying to create is sometimes better than pulling out your $275,000 simulator. And I think having an administration that understands the return on investment in simulation doesn't always translate to dollars. A lot of times it translates to students coming back for a second degree, or it translates to being able to shorten an orientation time when you're working with clinical partners. It's very hard to put a dollar sign or create that business model and just strictly look at monetary gain in simulation. You need to be open to looking at other types of return on investment.
Absolutely. Dr. Bloyer, what would you like to add from the financial side?
Oh boy. So once again, when I first got here at University of Miami 5 years ago, roughly 5 years ago, even in our own department, we really didn't have any kind of simulation. And really, like Dr. Susana Barroso just mentioned, that having a champion that really believes and thinks that simulation is valuable, and then having those leaders. So our chairperson really understood the value of having simulation, whether it is high fidelity simulation, or in our case, we have the rooms are set up with the hospital beds, that acute care setting. And we were able to tie it all together nicely, actually, as you know, as when the concept arose, how do we invest in this, because we don't have the high fidelity simulators, but we do have all the other oxygen and whatnot, right? And so the idea came back around full circle because it was tied into clinical education. So, for example, you know, our students that go into the acute care setting for those clinical experience, how can we prepare them for those experiences to manage all those lines and tubes, et cetera, before they get to that clinical experience? So that's how, I guess, that championed the creation of our 2 rooms that we have here with simulation. And then with the simulation at the nursing school, in terms of the finances, we've been fortunate enough because it's an IPE with nursing students, there has been no cost from our end. And that is thanks to the nursing school because it is an IPE. I do know that there could be some costs, and that's always a question that gets asked, you know, how do you pay for that? We're very fortunate at the moment. We've been able to demonstrate the value and the need for these simulation experiences, that the cost is overlooked, or not overlooked, but you know what I mean. Can't find the right word right now, but it's not the important thing. They realize the value. Obviously, in our case, we're doing a pediatric simulation. It's clearly written that entry-level competencies are not expected in pediatric education. However, our students I have right now, out of a cohort of 60, about 10 to 12 students that are really interested in pediatrics. And so when they go on those experiences, I want to make sure that they're prepared. And so our administrators are on board with that and have agreed to, you got to do what you got to do so that our students are successful in those experiences. So fortunate.
Excellent. And this is a great segue. I think you both have touched on the impact that this can have on clinical education and clinical education placements. You know, it's really a good simulation program is a selling point to your students, to your clinical instructors, to your university, to say, we can better prepare students to go out into the workforce and make a change. So I think you both have segued nicely into talking a little bit about your research. So we touched on your ELC presentation regarding your pediatric IPE experience, but I wanted to see if you both would touch a little bit more on a brief structure of the research that you've done and potentially what outcomes have come out of it so far. I don't know where you all are at in the outcome process and how much data you've collected, but I want to see a little bit more about this pediatric simulation experience. Dr. Bloyer, do you want to start?
So when we did, for the past 3 years, when we've done the simulation, we have collected data post the simulation as to the value of the simulation, and the IPE. So some of the questions are related to the simulation experience itself, and then some of the survey questions are related to the IPE experience. And as we presented, like you said, in ELC, the PT students 100% replied in the positive, so that they strongly agree that the experience was valuable, and both the high fidelity simulation and the IPE experience. prior years, I had done a little bit of survey pre-data, if you will, prior to the simulation. However, that wasn't, I hadn't set up the methods properly, so it's not really part of our current study. But I think maybe having in future studies some of that pre-data and post-data regarding the simulation experience would be good.
Excellent. Dr. Barroso-Fernandez, from the nursing side, what kind of outcomes are you guys seeing?
We're doing multiple different studies regarding simulation. My background is actually in disaster preparedness and response, and setting up an educational program involving simulation and preparing future nurses to actually be better equipped and more responsive to disasters. But when we look at the IP that Dr. Bloyer and I have done together, one of the interesting outcomes that we saw was our students, unlike the physical therapy students, actually were more resistant to having the PT I call it simulitis, because they've already had some simulation by the time we join with PT, and this is PEDS, which is such a specialty within our curriculum that they felt it was too many students and they didn't see the value of it. I think looking back on it, it's always easy to play Monday morning quarterback. A lot of it was the fact that instead of all of our students having that experience, it was one group of students that we were able to schedule. So 9 of our pediatric nursing students, instead of the whole cohort, had this experience. So it was different. None of their other friends got it, so they already felt singled out. Why were they sharing their time? And what was the value of it when nobody else was going to do it? Looking back, we need to be able to work on, and this was one of the things that we want to look at, is being able to extend it so that the PT students can be scheduled throughout the semester, and our nursing students will actually have the ability to work with the physical therapy students wherever they come in that curriculum.
I think you bring up a great point, both of you, and you allude to one of those challenges that I think we all deal with in simulation education is knowing that our cohort sizes are very different and our schedules are very different in learning, finding the right time, the right amount of students, and that right perfect point in their learning where it really affects them well. I know many of us have brought up that issue, and that's one of the challenges, but it helps when you have a great relationship, as it seems you two do, between the PT and nursing departments, to be able to have those conversations and work those. So kudos to both of you.
Absolutely.
So I'm going to ask a futuristic question as we lean in here. I view both of you as very innovative. The approach that you've taken in the pediatric research realm and simulation, you guys are doing amazing things at the University of Miami. However, I'm going to ask you both, if you could change kind of the future direction of simulation, and I'll ask it discipline specific, so simulation for physical therapy and simulation for nursing, what would you say should be the future direction that you want to head in regards to simulation education? And Dr. Barroso-Fernandez, we'll start with you and talking about nursing and simulation.
That's a great question.
Thank you for starting with her.
I look at it big picture. More simulation, more simulation that doesn't compete with clinical time, so that the nurse, and more interprofessional education simulation so that the students actually understand, when they're students, what it is to work together. And my biggest pet peeve is not forcing interprofessional education. I think a lot of times we end up ramming it down their throats, and because we're saying you have to do this together, there is some resistance. So from education, more meaningful. I don't think that students need to come in for 6-8 hours. I think you can actually do smaller simulation sessions, even within didactic lecture, to highlight certain points. I think as part of our accrediting body, our NCLEX, there should be a component where it's not just a written exam and students should have to go through simulation, because anybody can learn how to take a test, but can you be minimally competent in a simulation scenario? and be able to get your license from it. And I think when nursing students get hired, more of these residency programs and more of these orientations should also have a simulation component to go with them. Again, it's very different to be a nursing student, graduate, all of a sudden now you're a nurse, and there are certain expectations where we should be able to hit the ground running, but giving them that bridge from theory to practice, simulation fits in perfectly so that they're better graduate nurses, better new nurses, and decreasing burnout with better patient outcomes.
Excellent. All right, Dr. Bloyer, the spotlight's on you.
On me, the future.
You got to go second, so you got a little time to think. What would be your future direction for simulation and physical therapy education?
So absolutely, I do think that we should build those opportunities for our students to have simulation, not only in pediatrics but across the lifespan, which I know we are actively working on making sure that we build those opportunities for our students. So that's really the future right now, is making sure it's across the lifespan. And the other thing I want to talk about or mention about simulation is that, like Dr. Barroso mentioned a little while ago, it's not always the high fidelity things. You could use a lower, a different type of tool to make sure the simulation is taking place, whether that's using actors, using any kind of a simulation experience, so that the students really gain and learn from that in a low stakes environment. Obviously, it's not a high stakes environment. So what I don't want to see, I guess, the future is that simulation replaces any clinical education hours. And I do hear whatever I'm hearing may or might not be accurate, but I do hear that sometimes in certain environments, professions, etc., that simulation in the simulation hospitals can take place in place of those live simulation clinical education experiences. And I don't want that to be the future for physical therapy students. I still think that having all those experiences is definitely beneficial, but I think nothing replaces actually working on a real patient. So
absolutely. And Dr. Barroso-Fernandez, you want to add something?
25 studies have shown that 25% of clinical time can actually be simulation time without any negative outcomes for the patients or for the nurses themselves. So I think there is a window. I don't think that all clinical time should be simulation time, but I think that there is that control of certain experiences that simulation allows educators to handle. I use the example, if you have a group of clinicals of 8 students on an ortho floor and you just did a lecture on myocardial infarction, but they're all going to go on for hip replacement, the student may graduate and never see an MI, but you can control that in simulation. So there's certain things that I think where simulation really speaks to being able to make sure that there's a standard slot of patients or patient experiences that the student can graduate with. I agree with Dr. Bloyer. I don't think when we look at simulation, we all get so excited about high fidelity, but there are so many other pieces of simulation that give those learning objectives and have those learning outcomes where you don't have to turn on the $275,000 simulator that, again, speak to those educational moments and those aha moments for the students. And the other thing we haven't talked about, we're talking about simulation the way we're using it now, but there's a lot of simulation and a lot of, I think, future simulation that's going to be artificial and virtual reality, augmented reality, where, again, more interprofessional education is going to come from that. If you can sit at a computer screen, draw up your avatar and go into a busy acute care setting with med students, nursing students, PT, social work, which doesn't require the expense or the finances of building the simulation center. It's just a computer program.
Absolutely. I think you bring up some interesting points. First, that the study you referenced is actually referenced in the podcast that I talk about in the nursing study that looked at 25 and even up to 50% of clinical education, maybe possibly being supplemented with no effect in nursing results on the licensure examination. And even they looked at some post-grad results of employee hiring and things like that. That research, as far as I'm aware of, hasn't been done in physical therapy. And I think that's a great starting point of trying to see if that's even feasible, as Dr. Bloyer had said, if we can even go down that route of changing that. So I think that's a great point. Also, it's interesting when you talked about future of simulation and things like that. I know in physical therapy, one of the first forays that some schools have started to take is actual virtual anatomy tables for cadaver dissection. When we look at expenses of cadaver dissection and all of those things in lab space, they're actually looking at using virtual lab tables that are easy to maintain and much easier to reproduce each year. So great points from both of you. I really have enjoyed that. So at the Healthcare Education Transformation Podcast, we always close each show with kind of an open-ended question. And we give you the opportunity to think about this, but if you could change one aspect of healthcare education, whether it's nursing, physical therapy, or otherwise, what aspect would you change? And this doesn't have to be specific to simulation, but what would you change and how would you change it? And Dr. Bloyer, we're going to start with you because you got the easy hook last time of going second. So Dr. Bloyer, what could you change about healthcare education?
Oh, wow. What could I change about healthcare education? I guess right now, one of the areas that I definitely would like to see more are those integrated experiences, whether it is in simulation. And like I mentioned before, in pediatric education, it is hard to get those integrated experiences. So using simulation is definitely an avenue to do so. So some integrated experiences, more threaded throughout every class, not just in certain classes, but integrated experiences. And I really can't think of anything else right now that is on the forefront of my to-do list, if you will.
That's perfect. All right, Dr. Barroso-Fernandez, you're up. What would you change about healthcare education?
Definitely, I agree with Dr. Bloyer. More integrated experiences. I would love to move away from the way we test and looking at more understanding and application and hands-on high stakes testing and less computer Scantron, however, that pen and paper, pencil paper testing that really just shows, are you a good test taker? Moving away from those standardized exams and more hands-on, do you really get what you're doing?
Excellent. I love it. So I agree with you guys. Integrated experiences, again, we don't work in silos. We cannot survive in silos in the healthcare field. And as we continue to look at those educational experiences, the sooner the better. Let's expose our students as often as possible. So excellent. Well, with that, I want to offer up if you have any closing thoughts that you want to provide our listeners. Dr. Bloyer, any closing thoughts?
No, thank you for having us on today. And I say if you have any questions regarding simulation or thoughts about doing it, definitely reach out to us. But also don't be afraid of it, right? Don't be afraid to put these simulation experiences as part of a class, a lab. I think they're valuable, and starting small, starting off with like a clinical skills portion of a simulation is an ideal place to start. So thank you once again for this conversation.
Absolutely. And Dr. Barroso-Fernandez, any closing thoughts?
I agree with Dr. Bloyer. I think we all want to have really robust simulation programs and just weave simulation through every course. But you have to start small, learn from your mistakes, and then build your simulation program. It's not about quantity, it's about quality.
Absolutely. If our listeners need to reach out to you or want to get in contact with you, can you provide the best way for them to be able to reach you, Dr. Bloyer?
Yes. So my email is mhb79@miami.edu, and my cell phone is 305-298-3690.
Excellent. And Dr. Barroso-Fernandez?
My email is S as in Sam, B as in boy, ARRO, S as in Sam, O @miami.edu. And my cell phone number is 305-608-7299. I'm much better at texting than speaking. So if you drop me a text message, I will probably answer you much quicker than if you call me.
Excellent. Well, again, on behalf of the Healthcare Education Transformation Podcast and myself, I want to thank both of you, Dr. Bloyer and Dr. Barroso-Fernandez. Again, what you guys are doing at the University of Miami is fantastic, and your physical therapy and your nursing students are lucky to have you both as faculty and at the forefront of what you're doing in regards to education as a whole and simulation education. Thank you both for joining us today, and thank you again.
Thank you for having us.
Access to healthcare is one of the largest issues facing both providers and patients, as millions of people worldwide lack timely and affordable access to healthcare. Anywhere Healthcare, a telehealth platform, is a simple, low-cost option for providers and patients that eliminates the barriers to access to all kinds of healthcare. To find out more, check out anywhere.healthcare, which is available on our show notes. And if you use the code HET in all caps when you email to sign up, you'll save 25% off the total cost. Thank you for attending class today, and we hope that you learned something and gained value from the content.
If you'd like to schedule office hours with us, feel free to add us on Twitter at HET Podcast, on Instagram, HET Podcast, on Facebook, the Healthcare Education Transformation Podcast, and the homepage, healthcareeducationtransformationpodcast.com.
And for those of you following along in the syllabus, extra credit can be obtained by liking us, sharing us, and leaving a review.
Let's continue our journey up Mount Educational Success as lifelong learners.